So, this is dermatology and HIV. These are the AIDS-defining conditions commonly seen in dermatology. So, candidiasis, coccidiomycosis, cryptococcosis, herpes simplex, histoplasmosis, and Kaposi sarcoma, among others. Okay. About 90% of patients with HIV or AIDS have dermatologic diseases due to a defective cell-mediated immunity that leads to an increase in bacterial, fungal, and viral infections. Also, we see common na mga dermatologic or skin disorders, pero mas severe yung presentation nila if they have HIV or AIDS. So, these are the diseases associated with CD4 counts. So if the CD4 is less than 500, ang common is HPV infections, yung mga warts. If it's less than 200, these are the diseases that are common. And then pag less than 50, ito naman yung mga common. So mamaya, makikita natin sila. So here we are. Ito na yung question and answer portion natin. So this is the picture. What is the diagnosis? The case is of a 30-year-old male with erythematous scaly plaques on palms and soles. And some lesions are starting to appear also on the back. Sometimes makate, tapos wala pa siyang pinahid or nilagay na gamot. Okay, so we'll go through the differentials first para alam natin kung bakit syphilis yung sagot. So one of the choices was dyshydrotic eczema. This is the picture on the left. It starts as vesicles, no? So parang butlig na may tubig na makate. Usually hands and feet yan, may history of eczema yung patient or contact with an irritant, no? And then the one on the right, this one is erythema multiforme. So these are target-like lesions na flat, no? So hindi sila masyadong nakaangat. So flat lang yan. And then it's usually associated with either a preceding viral infection or commonly drugs na iniinom. So yung mga gamot, no, na iniinom. And then, this one is contact dermatitis. So, pwede siyang maculopapular, so flat or nakaumbok na mga pula-pulang dots and ganyan. So, ito yan. Ang important dito sa history nito is dapat meron siyang contactant. So, may nahawakan or the patient came into contact with something before developing the lesions. And this is a picture of a patient with syphilis. So, maculopapular, scaly na rashes on palms and soles commonly. So, secondary syphilis yon pag ganon. So, to further confirm the diagnosis, you can ask the patient kung meron ba siyang history of painless lesions on the genital area, but this is usually missed. So, the patients don't generally report this kasi painless nga siya. So, hindi nila napapansin na meron silang ganon. So, you can ask about the sexual history, kung kailan yung last, kilala ba niya yung alam ba niya yung sexual history ng partner niya. And then you can also ask if the patient has any meds taken for maintenance or allergies to medications. Kasi sa treatment natin, ang ibibigay usually is PenG. Kung may allergy, pwedeng i-desensitize or pwedeng mag-second line, doxycycline or tetracycline. And then also, it's important to test for other STDs and do a follow-up of your labs, so RPR, TPHA, to check kung nagre-respond siya sa treatment, and then also advise your patient to treat the sexual partner and behavioral modifications for next time. Okay. So this is the second case of a 51-year-old male with vesicles on an erythematous base associated with pain, but there's no fever. So what is the diagnosis? So, varicella ang choices pala, no? Anyway, nandun na siya. So, okay. So, yung tamang sagot nga natin is herpes zoster, no? So, varicella will present with vesicles and pustules. So, parang may nana, tas merong mga butlig na may tubig, tas usually makate. Tapos, generalized in distribution all over the body. May precedent na fever or malaise before magkaroon ng lesions. And then, herpes zoster, it's usually dermatomal, no? So, isang lang siya, isang part ng katawan, either left or right, rarely ever crosses midline, Pero in cases of severe immunocompromise, pwede tayong magkaroon ng disseminated herpes zoster. So mukha siyang chickenpox, mukhang ganito, pero masakit siya. Tapos nagka-chickenpox na siya dati. So, sorry mali yung picture nito. So, ito kasi yung totoong sagot disseminated herpes zoster. So, disseminated, ito na lang, dito na tayo sa cutaneous autosensitization. So, this picture is of a patient na merong initial other na mga problema. So, pwedeng fungal infection or mga allergic contact dermatitis, tapos kumalat sa buong katawan. So, ganyan yung itsura niya. Papules din and may vesicles din sometimes. Okay, so when you get back to your patient, you should ask the patient if he or she has a history of exposure to anyone with varicella or herpes zoster. And then any recent illnesses and other comorbidities or may stress ba siyang na-encounter recently bago nagkaroon ng mga lesions. Also, sometimes patients will report na may masakit muna bago lumabas yung mga lesions. Yun. So, herpes zoster in HIV has a 15-fold higher incidence and is associated usually with CD4s of less than 200. And there's a 10% risk of recurrence in 1 year. So, pwedeng umulit ito. And then, usually we treat them with valacyclovir, 1 gram, 3 times a day for 7 to 10 days, depending on severity. So usually, papa-follow up ka ng 7 days. Kung okay na, edi tama na. Pero kung meron pa, you can extend up to 10 days. So you should advise your patient na mag-isolate siya kasi pwede naman siyang makahawa, especially if immunocompromised din yung mga kasama niya. So yung mga buntis, sanggol, or ibang may mga malulubhang sakit, sila yung dapat mag-avoid dun sa patient natin. Okay, you can also give pain medications and tell the patient not to manipulate the lesions, and the patient may infect others until the crusts fall off, which takes about 2 to 3 weeks. So this is our next case of a 22-year-old male with erythematous papules and macules on the trunk, bilateral upper and lower extremities associated with pruritus, and occasional low-grade fever. So what is the diagnosis? The choices are adverse drug reaction, scabies, allergic contact dermatitis, or dermatitis herpetiformis. So we'll go through the differentials first. This is allergic contact dermatitis. Again, a history of contactant prior to development of the lesion. So pwedeng maculopapular or vesicular din yung eruption anywhere on the body that the contactant touched. Ganyan. So urticaria, ito naman parang yung mga pantal, no? So wheels na kapag pinindot natin, nagba-blanch or nagiging puti. Tapos pag pinakawalan natin yung area kung saan natin siya pinindot, pupula siya ulit. Okay, yung urticaria naman is can be caused by several different, kasi ang daming kinds ng urticaria eh. Pwede rin naman ang gamot na mag-cause ng urticaria. Pero yun yung itsura ng lesions. So, ito naman, scabies, we look for burrows, commonly found dun sa gitna ng mga daliri natin. So, they also present with maculopapular lesions and also some vesicles na excoriated. And this is dermatitis herpetiformis na commonly associated with intake of certain foods and more common in Caucasians. So, ito yung pwede natin tanungin sa patient kung meron ba siyang history of drug intake in the last 2 months. So, remember na up to 2 months, pwede pa rin mag-cause ng reaction sa katawan ng pasyente ang pag-inom ng gamot. No? Hindi agad-agad yon. And then, history of allergy to drugs, food, or other mga kung saan man siya allergic. And then also, if the patient had an intake of multiple drugs na bago, isulat natin lahat para ma-eliminate natin yung most likely offending drug. So, how to treat this patient? Withdraw the offending drug. You can give topical and oral steroids and hospital admission if necessary. Okay. So, this is the next case. Picture lang siya. Walang story. So there are umbilicated papules on the genital area. Ayan. So the choices are condyloma lata, condyloma acuminata, scrotal milia, or molluscum contagiosum. The next one is this one. So what is the diagnosis? You have the same choices, again, condyloma lata, acuminata, scrotal milia, or molluscum contagiosum. So this one is molluscum contagiosum. Okay, and then the second one, this one, that's condyloma acuminata. Okay. So, we treat these patients, both of them pwedeng electrodesiccation. For molluscum, tatanggalin natin yung laman sa loob also. And then, follow up every 2 weeks until all lesions are cleared because the lesions are highly recurrent, especially in the genital area. And then, for HPV, we advise vaccination. Ngayon, may bagong labas na nanovalent vaccine. So, yun yung current recommendations for that. Okay. So, ayan. Ay, sorry. Baliktad. Okay. So here, what is the diagnosis? We have a patient, male patient with erythematous scaly plaques on the ears. The choices are allergic contact dermatitis, seborrheic dermatitis, psoriasis vulgaris, and pityriasis zika. So seborrheic dermatitis, we treat this with topical steroids or antifungals and topical immune modulators. Pwede ring oral antifungals pag severe. So the predilection sites are V of chest and back, tapos sa hairline, and then in between the eyebrows, nasolabial folds, and the ears. And then we can also give ketoconazole 2% thrice a week for 4 weeks. Okay. Ito naman. So what is the diagnosis here? We also have erythematous scaly plaques on the hairline, but it extends beyond the hairline. So, ang choices natin are the same: allergic contact dermatitis, seborrheic dermatitis, psoriasis, or pityriasis zika. The answer is psoriasis vulgaris. So, unlike seborrheic dermatitis, it extends beyond the hairline, and also we have other areas of the body affected. So, flexural areas usually yan, mga elbows, knees, depende din sa type ng psoriasis. May inverse din kasi, so extensor areas pala yun. So yung inverse yung nasa flexural areas, no? Yun. So meron din sa back yung gouty types. Depende siya kung anong type ng psoriasis. Pero generally, we have thicker scales and then mas red yung base niya. And also we have associated nail changes. So for psoriasis, we treat with topical steroids or topical calcineurin inhibitors, oral keratolytics, methotrexate, pero medyo mahirap na maghanap yan. Pero we never give oral steroids for patients with psoriasis. Yung hanggang pamahid lang tayo na steroid. Okay. So, ito naman, what is the diagnosis? So, these are plaques on the tongue. Whitish plaques on the tongue na hindi natatanggal pag siniscrape off. Okay, so ang sagot nito ay oral hairy leukoplakia. So, in general, if you give ARVs, bababa din naman yung lesions. Pero for some patients that are bothered by how it looks, you can give them acyclovir, 800 milligrams 5 times a day for 7 to 14 days. Okay, so this one naman is sa may back ng throat. Yan. So, mga whitish din na plaques na kapag skin rape off natin siya, kunyari kumuha ng depressor, tapos kinutkot mo siya, sumasama siya. Okay. So, ang sagot niyan ay oral thrush. So, may different types. We have pseudomembranous erythematous and angular cheilitis, and they're all treated with oral antifungals or pwede ring topical antifungals. Okay, so this is the last. We have 32-year-old male, pain nodules on the left thigh. ARVs were started 2 weeks prior to appearance of lesions. And then the CD4 of 23. So the choices are melanotic melanoma, Kaposi sarcoma, erythema nodosum, or basal cell carcinoma. Okay, so the answer is Kaposi sarcoma. Okay, to go through, yan. Ito yung itsura ng amelanotic melanoma. Pwedeng sun-exposed or non-sun-exposed na areas siya natatagpuan. higher likelihood of finding this in Caucasians, pero pwede rin yan sa Asians. Usually sa Asians, sa paa siya nahanap. And this is a photo of erythema nodosum. They also present with painful nodules on the lower extremities, commonly affecting women. Pero pwede rin naman yan sa males, and then be associated other mga sakit, pwedeng TB or any other inflammatory process. Okay, and then this is a picture of basal cell carcinoma, pwedeng found on sun-exposed areas. No? And then ito, Kaposi sarcoma, anywhere on the body siya. So mas violaceous siya, mas purplish yung itsura niya, purplish and red compared dito. No? Okay, so how do we treat this patient? We can do chemotherapy if the lesions are obstructive kasi pwede nito sa loob ng katawan. And then kung nasa labas lang siya sa balat, pwedeng i-excise if the lesions have ulceration or are associated with pain. We can also give biologics, radiation therapy, and they also respond with initiation of ARVs. So, minsan lumalabas siya pag binigay, tapos bababa din siya ulit after a while. Thank you.